Okay. Good morning, good afternoon, everyone. Thank you and welcome to this webinar. Before I do a formal welcome, maybe Chantel, you can take us through the housekeeping rules, and then I will have an official welcome to everyone. Chantel, just do the housekeeping, please.
Sure. Okay, so just a few housekeeping for people who are not sure. In terms of, we're going to have a session after the presentations for a discussion. But please, during the presentations, if you have any questions as they arise, please use the Q&A function to type your questions in. So that's the one thing. And then there is interpretation available. There's an icon that provides the interpretation channels, FR for French and PT for Portuguese. So please choose the interpretation channel if you require interpretation. Okay, over to you, Ben.
Thanks, Chantel. So my names are Benjamin Kagena, and I'm the director of NICHE, which is the NITAC Support Hub project. And this project is based at the University of Cape Town. And on behalf of the NICHE project team and partners, including the WHO, I'd like to welcome you to this webinar series. And the purpose of this webinar series is to improve the knowledge and provide up-to-date information on current and future trends in specific topics around vaccines. And also, this webinar series is aimed at providing a forum for NITACs through which they can share information on issues relating to the use of evidence in their settings to make decisions. So for this is webinar number 4. We've already done 3 webinars. And for this webinar number 4, the topic is on emerging evidence on the efficacy and effectiveness of a single-dose HPV vaccine and what this means for the African region. So for this webinar, we are co-hosting with Nigerian NITAC, and I'm going to hand over to Professor Ibrahim, who is the chair of the Nigerian NITAC. But just before I hand over to Professor Ibrahim, I would like to mention to you all that there's a link that is going to come into the chat box. And this link is going to take you to a survey which has 2 questions to ask you about the topics that we should prioritize to focus on for the next 5th, 6th, and 7th webinar. So it's just 2 questions that should not take you more than 2 minutes. You can complete it now or during the webinar or even afterwards, because it's going to stay active for the next couple of days. And with that, I'll hand over to Nigerian NITAC chair, Professor Ibrahim, to take us through the next part of the program. Over to you, Professor Ibrahim, and thank you. Professor Ibrahim, we can't hear you. Professor Ibrahim, we can't hear you. Can you hear him, Chantal?
No, I cannot.
Maybe Sarim, as we probably you may be having some audio problem. Maybe before, as we try to get Professor Ibrahim sorted, maybe I can, because for the interest of time, maybe I can welcome the first speaker and thank you so much to all the speakers who have kindly and agreed to come and share their expertise with us on this topic. And also thanks to Nigeria NITAG for agreeing to co-host this webinar with us. So maybe we can go to Dr. Nelly Mogo, who is going to give the keynote address on the evidence on the efficacy and effectiveness of a single dose HPV vaccine. And I think after that, Nelly, Hillary can join us for the next talk. Hopefully by that time, Professor Ibrahim audio will be sorted. Over to you, Nelly.
All right. Good morning. It's morning in Nairobi, Kenya, where I'm talking from. I'd like to really start by thanking Nish for this invitation to share our data that we've accrued on single-dose HPV vaccine. We'll be doing this together with Hillary, who will be presenting their data from Mwanza, Tanzania, and our data is gathered from Nairobi, Kenya. Just a little bit of correction. I have worked with the University of Nairobi, but I'm currently with the Kenyan Medical Research Institute and also work as faculty at the University of Washington. So there's a lot, and Hillary will talk a little bit more broadly on other data on single dose, but I'll be presenting data from our trial, which is called KENSHI, which looked at efficacy of single dose HPV vaccine amongst young African women. And my co-protocol chair for that grant, actually the lead protocol chair, is Ruan Barnabas, who's currently with the Harvard University. This work was done by a collaborative team as listed there, with 3 KEMRI research facilities that did the implementation, University of Washington and the Fred Hatch. So we know that the most impacted areas by cervical cancer is East and Southern Africa. And we know that the story that we have 42 low middle income countries carrying almost 90% of disease burden and mortality. The uptake of vaccine, of the HPV vaccine, has been very low, though it's coming up in several countries, but it's also been lowest in the areas where we have the highest disease burden. As you can see from the chart, the darker blue is where we have more disease. Now, I'll not talk a lot about the rationale about the WHO cancer elimination strategy, because I know Paul Bloom will talk about that. But the published 15% coverage of immunized girls falls very far behind the goal, the elimination goal of 90%. Now, this observational study, and Hillary will talk more to this, she'll show you some data from observational studies that showed efficacy after follow-up, extended follow-up of up to 10 years. But you know, we always want RCTs, as you know, in WHO assessment of quality of evidence, RCTs always come out as the strongest evidence. So why single dose? If we look at a vaccine uptake, there's higher uptake of the first dose, and a lot of children in the world or women in the world do not attain the second dose. Now, single dose is definitely easier to deliver and cheaper overall. And we're coming out of a time where there has been shortage of vaccines. So this trial was done to close the evidence gap and give policymakers the evidence they need to make the right recommendations for HPV vaccine schedules and increase uptake and coverage and access. So the trial that we conducted had 2 primary goals. One was to test the efficacy of an immediate single dose of the nanovalent or bivalent, that's Cervarix HPV vaccination, to prevent incident persistent HPV 16 and 18. Secondly, is to test the efficacy of immediate single-dose nanovalent HPV vaccine to prevent incident persistent HPV 16, 18, 31, 33, 45, 52, 58. These are the ones which are covered, the oncogenic HPV types covered in the nanovalent vaccine. So our results will speak to both of these objectives. So as I said, this trial was conducted in 3 clinical trial sites under the Kenya Medical Research Institute. It was a randomized double-blind control trial. We enrolled young women ages 15 to 20 who had at least 1 to 5 lifetime sexual partners, were confirmed to be HIV negative with a rapid test, hadn't had prior HPV vaccine or contraindication to vaccine, and were randomized to the 3 arms. So they either got the nanovalent vaccine or the bivalent vaccine or the meningococcal vaccine, but this was what we call delayed HPV vaccine arm. And the intention, which has been concluded, was to make sure that all the enrolled participants ultimately will be vaccinated, because this is a vaccine which we know works. So we saw these young women were randomized in 3 equal groups to those groups, and were seen at baseline at month 3 with a self-test HPV, and then we had HPV testing done every 6 months. And the data I present is for the first 18 months, so we continue with follow-up, and I'll show you what we found. So the first result, which was published at month 18, looked at vaccine efficacy amongst people who tested HPV negative at enrollment. But we also analyzed data for everybody, whether or not they're HPV positive or negative at enrollment, because we know we're not going to screen our population for the HPV status before we can vaccinate them. So we enrolled this cohort between December 2018 and 2019. We didn't have any differences across the 3 arms. 57% of the cohort was between age 15 to 17, and 61% had 1 lifetime sexual partner. When we looked at HPV infections, 29% of participants had HPV 16/18 DNA positive at enrollment. And this is important to note because it sort of tells us what our population level of HPV infection is likely to be. So for the first modified intention to treat, this group was not included, but remember I said we still analyze with them included across the arms. And for the nanovalent oncogenic types, 52% had at least 1 of them positive by month at enrollment or month 3. So only 615 were included in that analysis for the modified intention to treat analysis. We've had really good retention in this cohort, which I think is really credit to the research team, given the age of the cohort. And we've been able to get most swabs across board, and we have up to 94% had given us at least 3 time points of infection. So this slide is important because it tells us that this cohort was at risk of infection. So we looked at the incidence of non-vaccine HPV infections across the 3 arms, and you can see that in the nanovalent, bivalent, and meningococcal delayed HPV vaccine arm, there was equal incidence of non-HPV vaccine types. So they were sexually active and they were not protected from just anything else. I haven't presented to you the STI data. There was equal gonorrhea incidence and chlamydia across the 3 arms to remind us that they were sexually active and again, not protected. So this is the data that excited us. When we looked at the bivalent that's across in the two groups, for HPV 16 and 18, there was one incident case in the nanovalent arm, one incident case in the bivalent arm, and 36 in the delayed meningococcal vaccine arm, with a vaccine efficacy rate of 97.5%. We were very, very excited with these results. And being in the vaccine world, you know this is very high efficacy rates. Now, when we looked at the nanovalent HPV infections, there were 4 incident infections in the nanovalent arm and 29 in the meningococcal arm. And I want to say that these infections all occurred before month 6. So with about 90% vaccine effectiveness of protection across all the 7 types of oncogenic HPV types protected by that vaccine. So then we did further analysis that included everybody. And what we looked at wasn't just incident HPV infection, we're looking at persistent, because we know for cervical cancer or oncogenic lesions, what really matters is the HPV infection, that persistent stays. So that's what was so important, to have the continuous follow-up and confirmation of infection. Yeah. So you can see that when we excluded participants with HPV DNA detected at month 6, there was no incident infection, telling you that as a prophylactic vaccine, this vaccine is highly effective. The top part of these charts that shows you 1 and 3 includes people who had HPV antibodies at enrollment, which is more what you would expect from the general population, because as we aim to extend the age, which is what we wanted to show in this, then we expect that we will have girls who already are sexually active. Sorry about that. So again, as I said, this is when we included everybody, and these are the results that we have. But as we said, when it comes to vaccine efficacy, 95% and 90% is a highly efficacious vaccine. So from this study, we were able to show that adolescent girls and young women were effectively protected from HPV infection over the first 18 months after vaccination. And the vaccine efficacy rate of 97%, more than 97%, is in keeping with what has been observed from the trials of the legislative trials with 3 doses. We also noted that we had very high incidence of HPV infection in the delayed meningococcal arm, more than we had seen before. And this is a trial where we were very keen to confirm the outcome of HPV infection, and had high fidelity and high retention, providing very strong evidence for single-dose HPV vaccine efficacy. We have crossed over all the participants. So everybody in the delayed meningococcal arm, delayed HPV arm who had meningococcal vaccine has currently also now been vaccinated, but this was done blindly and they got the nanovalent. So they don't know who was on which arm, and we continue following them up. So we will have more data, and this is the large study team. And when Hillary presents, she will share data that will help us understand that this 18 months and the additional work that they've done is enough evidence to support long-term effectiveness of this vaccine. So thank you very much.
Thank you, Nelly. Is it okay for me to continue?
Please.
Yes, I think you can.
Perfect, thank you. Can you see my slides?
Yes.
Let me just try to share
Yes,
them.
slide
There we
is
go.
visible.
Okay, fantastic. Thank you. So my name is Hilary Whitworth. I'm a scientist at the London School of Hygiene and Tropical Medicine. I lived in Tanzania for about 6 years, partly working on this trial. So I just want to start by thanking the organisers for giving us the opportunity to co-present with Nelly today. I'm going to present on behalf of the trial investigators the DORIS trial, which is a randomized trial evaluating single-dose HPV vaccination in Tanzania. These are my disclosures. So I'm going to largely skip over the background because Nelly's already presented this, but just to really reiterate, there is accumulating evidence that a single dose of HPV vaccine could protect against HPV, and this could be hugely beneficial in that it would simplify vaccine delivery and reduce the costs and number of vaccine doses needed. There is a growing body of evidence supporting single-dose HPV vaccination. Some of this is observational evidence, and I'm going to talk about a couple of these observational studies shortly. And now, importantly, there are data from 2 randomized trials from sub-Saharan Africa, the Kenchi trial, which Nelly has just presented, and the Doris trial, which is the focus of my presentation. So some of the observational data comes from the Costa Rica vaccine trial, CVT. So this is a randomized double-blind trial comparing 3 doses of Cervarix to a control vaccine, hepatitis A vaccine. In this trial, some participants missed some of their vaccination visits and therefore only received 1 or 2 of their vaccine doses. But the investigators followed them up regardless, and what this meant is that they could then compare the vaccine efficacy in those women who received 1, 2, or 3 doses. This is considered observational because those women were not prospectively randomized to receive 1 or 2 doses. In any case, now those women have been followed up for 11 plus years, and so far the investigators have found no evidence of a difference in vaccine efficacy against HPV 16 and 18 infection across those dose groups. So this graph shows the HPV 16 antibody levels in 1 and 3 dose arms from the Costa Rica vaccine trial up to 11 years post-vaccination. You can see that the antibody levels were higher in the 3-dose arm compared to the 1-dose arm, but the levels in the 1-dose arm were remarkably stable up to that 11-year time point. There's no evidence that those levels are starting to drop. And remember that the investigators demonstrated efficacy in that 1-dose group. So more observational evidence comes from the IARC India vaccine trial. This was originally designed as a cluster randomized trial of 2 versus 3 doses of Gardasil. However, during the enrollment phase of that trial, India suspended all HPV vaccination trials in the country for reasons unrelated to this specific trial. And again, that led to some girls only receiving 1 vaccine dose. And so by following up those girls, the investigators could compare vaccine efficacy in the 1, 2, and 3 dose participants, again, being observational analyses. The girls and women have been followed up now for 9 years. And again, there's no evidence of a difference in vaccine efficacy against HPV 16 and 18 infections across those dose groups. So coming on to the DORIS trial, this is a randomized unblinded trial comparing the immunogenicity and safety of 1, 2, and 3 doses of 2 different HPV vaccines. It's been conducted by the Mwanza Intervention Trials Unit, which is in Tanzania. And in brief, 930 HIV negative girls aged 9 to 14 years were randomized to receive either 1, 2, or 3 doses of Cervarix or 1, 2, or 3 doses of Gardasil 9. And they are being followed up to month 60, and the month 36 results are now available. And this is a really important trial because it's the first randomized trial of single-dose HPV vaccination in the target age group. So there were 2 primary objectives for the DORIS trial. The first was to demonstrate non-inferiority of HPV 16 and 18 antibody seroconversion for one HPV vaccine dose compared to 2 or 3 doses of the same vaccine type at month 24. And the second was to demonstrate non-inferiority of HPV 16 and 18 antibody GMCs at month 24 when comparing one vaccine dose in DORIS with historical efficacy cohorts who only received 1 dose. So before I go on to the study results, I just wanted to provide some detail on how non-inferiority was defined in this study. So as I mentioned, the first primary objective was based on non-inferiority of seroconversion for 1 dose compared to the multi-dose schedules. In order to meet non-inferiority, the lower 95% confidence interval for the difference in seroconversion between the 1-dose strategy and the multi-dose strategies had to be above -5%. So, i.e., the 1-dose strategy could not reduce seroconversion by more than 5%. So this is demonstrated in the example figure on the right, where the coloured dots show the example point estimates for the difference in seroconversion, and the lines show the 95% confidence intervals. And if the point estimate and the 95% confidence intervals fall to the right of that red dotted line, we meet the criteria for non-inferiority. And this is a standard margin that's been used in other trials. So this table shows the proportions of participants who were seropositive for antibodies to HPV 16 and HPV 18 at the month 36 time point by the vaccine type received and the number of doses received. And as you can see, seropositivity was very high across the board. Almost all girls were seropositive for antibodies to HPV 16 and 18 at that month 36 visit. So looking at the non-inferiority analyses, this figure on the right shows the comparisons of the different dose schedules for HPV 16 for Cervarix and Gardasil 9, and for HPV 18 for Cervarix and for Gardasil 9. And you can see that for most comparisons, the point estimate for the difference in seropositivity and the 95% confidence intervals fall to the right of that red dotted line, meaning that non-inferiority was met. So these graphs show the HPV 16 and 18 antibody levels over time up to 36 months post-vaccination in the participants who received Cervarix. And this is shown by dose group, with 1 dose group shown in blue, 2 doses in green, and 3 doses in red. You can see for all of the arms, the antibody levels typically reach a peak 1 month post their last vaccination, and then they decline but reach a plateau around the month 12 visit. The antibody levels in the 2 and 3 dose arms are higher than for the 1 dose arm. This is as we expected to see based on the previous studies, for example, the CVT data which I showed earlier. However, again, the 1 dose levels are very stable over time. There's no evidence of a decline in the antibody levels in the 1 dose group by the month 36 visit. So this is the same slide, but for Gardasil, and here again we see a similar pattern as we saw for Cervarix. So this graph shows the antibody avidity index at month 36. So antibody avidity is an indicator of the strength of the binding of the antibody to the antigen. So on the left-hand side, we've got the girls who received 1, 2, or 3 doses of Cervarix. And on the right, we have the girls who received 1, 2, or 3 doses of Gardasil 9. The HPV 16 avidity is shown in red, and the HPV 18 avidity is shown in blue. And you can see that there's really no evidence of a difference in antibody avidity between the 1, 2, and 3 dose recipients, both for HPV 16 and for HPV 18. So just as a reminder, the second primary objective in DORIS was to compare 1 dose in DORIS with 1 dose in these historical efficacy cohorts, and this used immunobridging methods. So just to provide a little bit of background and rationale to that, it can be really difficult to evaluate efficacy for HPV vaccines in girls of the target age range because those girls are typically not sexually active. So you need to follow them up for a long time in order for them to become sexually active and start acquiring those HPV infections. The WHO has recommended that immunobridging studies are appropriate in certain circumstances, whereby immune responses are bridged to populations where efficacy has already been shown. So non-inferiority has been agreed to be an appropriate trial endpoint for this, and non-inferiority of immune responses can be used to infer efficacy. So in this study, what we did was to immunobridge the antibody levels seen in the one-dose participants in DORIS at the month 24 time point to the antibody levels seen among girls and women who received one dose in the CVT in IARC India trial and Kenshi trials where efficacy has been demonstrated. So again, this objective used non-inferiority endpoints, but here we were largely looking at the ratio of the geometric mean concentrations for one dose in DORIS versus one dose in historical cohorts. And here, in order to meet non-inferiority, the lower confidence limit for the GMC ratio had to be above 0.5. So again, we were looking for that point estimate and the 95% confidence intervals to be to the right of that red dotted line. So this table shows the baseline characteristics of the comparison groups for this immunobridging. So on the left in the orange box, we have the one-dose DORIS and the one-dose CVT participants, all of whom received Cervarix. And on the right, we have the one-dose DORIS versus the one-dose India trial participants. And here, the DORIS participants received Gardasil 9 and the India participants received Gardasil. So this graph compares the HPV 16 in red and HPV 18 in blue antibody levels in participants who received one vaccine dose in DORIS versus one vaccine dose in CVT, and participants who received one vaccine dose in DORIS versus one vaccine dose in the IARC India trial. And as you can see, the antibody levels observed following one vaccine dose in DORIS were at least as high as the antibody levels observed following one dose in CVT in India, where efficacy has already been demonstrated. So this slide shows the non-inferiority analyses. My apologies, this is quite a cluttered slide, but if you focus on the figure on the left-hand side, this shows the comparisons of DORIS and CVT with HPV 16 shown in red and HPV 18 in blue. And then we have the DORIS and IARC India vaccine trial comparisons. And as you can see, all of those point estimates for the GMC ratio and the 95% confidence intervals fall well to the right of that red dotted line, meaning that non-inferiority was met. As I mentioned, we also immunobridged to Kenshi. I'm not going to go through the details of Kenshi because obviously Nelly has just presented that, but just to remind everybody that in Kenshi at that month 18 visit, vaccine efficacy against HPV 16 and 18 infection was very high for a single dose of HPV vaccine. It was 97.5% for both Cervarix and for Gardasil. So this graph shows it compares the HPV 16 and 18 antibody levels for one dose in DORIS versus one dose in Kenshi for Cervarix recipients and for Gardasil 9 recipients. And again, you can see that the antibody levels for one dose participants in Kenshi were very similar to the antibody levels for one dose participants in Kenshi. Again, showing the non-inferiority, focus on the figure on the left-hand side. This shows the comparisons for DORIS against Kenshi, for Cervarix and for Gardasil. And again, we see that the point estimate for the GMC ratio and the 95% confidence intervals are well to the right of that red dotted line, meaning that non-inferiority was met. So these are really excellent vaccines. very immunogenic. In DORIS, we found that almost all participants had antibodies against HPV 16 and 18 at that month 36 time point, regardless of the number of doses received. The antibody levels by dose and vaccine and the trajectories over time were consistent with what we've seen in previous studies. And we saw very stable antibody levels in the one dose arm from that month 12 to month 36 visit. And we also saw no difference in avidity between the 1, 2, and 3 dose arms. Several other studies in older girls and women have now demonstrated efficacy for HPV 16 and 18 endpoints with a one-dose regime. And here we've demonstrated in the target age range for HPV vaccination that the immune responses seen with one dose of HPV vaccine are non-inferior to the antibody levels observed following one dose in women where efficacy has been demonstrated. There are some evidence gaps, particularly we need further information on dose reduction in HIV-infected girls. However, this evidence base behind single-dose HPV vaccination is now sufficiently strong that a number of countries are considering moving to or introducing a single-dose strategy. So just to finish on my acknowledgement slide, these are the DORIS and immunobridging investigators. I'd just particularly like to acknowledge the DORIS chief and principal investigators, Deborah Watson-Jones, John Changalucha and Kathy Baisley, and of course to acknowledge the DORIS trial participants and parents, the DORIS study team and the DORIS funders. Thank you. My apologies, I realized I forgot to share my video during that.
Thank you very much. We've listened to two powerful presentations. Nelly and Hilary, we want to thank you very much for those very, very, very convincing illustrations of the 1, 2, 3 doses. And of course, reactions will be expected as usual, and you make your notes and ask the questions at the end. I think we want to, let me apologize for not surfacing earlier on. For one reason or the other, I could hear everybody, but nobody could hear me. And I think we can then, in the interest of time, go on to the next presentation, which is to be given by Dr. Oposin. Dr. Oposin, over to you.
Thank you very much, Professor. Do I understand well that it's my turn now to present before Dr. Oposin?
Oh, my apologies, please. My apologies. Please go ahead.
Thank you very much, and thank you for confirming that you're well seeing the full screen presentation. It's really a pleasure to present today. I add in that to the words we heard from Nelly and Hilary, and also really a pleasure to present following the presentations by these two researchers involved in this important research. So I will give some background on SAGE recommendations that was made based on the evidence we were just presented. And so we'll have a little look at the programmatic relevance of optimized HPV schedules, quickly come back to the evidence, and then look at some of the implications as well as the guidance that is now has come from SAGE and that WHO will take and include in its upcoming position paper. So we heard about the global strategy for elimination of cervical cancer, and one of the challenges will be that all countries need to introduce and need to reach 90% coverage. And if we think about introduction, and we see the situation in Africa, we see that like in many parts of the world, high-income countries have mostly introduced, but middle-income countries and Gavi countries still have challenges introducing, because this remains an expensive vaccine. So when we look at coverage, we know we also have challenges. This is the global coverage, so that doesn't represent what happens in individual countries, but we can see that not all cohorts of girls are being covered in the world, and also that in the last couple of years, due to COVID, vaccination has gone down quite considerably, almost 25% in the case of HPV. So we really have a challenge. And here you can see a little bit the situation in the African setting. While we are well underway to cover a larger percentage of the population, as you can see on the left, you can see on the right as well that countries have been impacted in a different way, but by the COVID situation over the last years. And so in green, you see countries where the rates have been affected in a less big way, whereas in red, the countries where either countries interrupted vaccination or the coverage rates have gone down a lot. So coverage in itself is a challenge. Another challenge is, and that's not shown here, is that there's high dropout rates in many countries. So it's challenging to deliver the 2 doses to all the population. We've had lots of challenges with the vaccine supply, and therefore we maintain a global supply situation study and update it regularly. This is the latest update that was presented to SAGE. And the main thing to say is that by now, luckily, we are seeing the supply situation improving. So while in the short term, there are still some challenges dealing with introductions, and particularly with big cohort sizes, we think that the supply challenges will cease to exist in the midterm, and potentially also in the short term when we start using 1 doses in introductions. So I think the main point is that for SAGE, supply situations was not the main reason to come to the conclusion that we can improve and optimize the HPV schedule, but really it was based on the evidence. So I think we got in the presentations by Nelly and Hilary a really good overview of what was the key data. And Hilary described it as observational data from CBT in India, and she's right. But they were also trials, as she explained, that were interrupted. So this is better quality data, although not the best. It's not the purposeful randomized controlled trials. And that's the data that we did get from Kenshi and also from Doris. So this is the key evidence, and you've heard all about it, all the details that SAGE looked at. And I think particularly seeing that with the 1 dose, we have such high efficacies that it's very unlikely that there is a difference between 1 and 2 doses when we get this head-to-head comparison in a trial that's currently underway and that will give some data in 2 to 3 years' time. So this really made SAGE see that the total body of evidence is really very convincing. It also looked at another group of observational studies that were not trials, but more population-based registry data, and they also showed the same direction. You can see on the right side that the red dots indicate there's high risk of bias. So this is really lower graded evidence. But as you can see in the forest plot, there's hardly any difference between 1 and 2 doses in the outcomes, in this case, high-grade lesions, and I just wanted to show you. So this is data that we have gathered in a systematic review by the Cochrane response group. Another type of data we looked at is modeling data, and so we looked at can a 1 dose be useful for use, particularly in these multi-age cohort catch-up campaigns, and then also to look at can it be useful in routine vaccination. And this data was done in this case, as you can see, based on India, but it is quite, the patterns are similar in other countries. And the main point I wanted to show is that when you compare to a routine program without a MEC, and then you add this catch-up MEC, that whether it is 100% efficacy, same efficacy as for 2 or 3 doses, or a lower efficacy, which is shown in the green bar, where the modelers took 85% efficacy, then you can see that actually you can still have a huge additional impact of around 600,000 or 700,000 cases averted in the case of India, and that there's hardly any difference between using a one or a one dose with the 85% coverage, or vaccine efficacy, or the 100% efficacy. So that was very reassuring. When we look at the long term, so in the blue line, you can see what would happen if indeed 2 dose has the same efficacy as 1 dose, which is what we currently think and what SAGE concluded based on the current evidence. So we now think that with 1 dose, we would follow the blue line. But if we assume that 1 dose had 85% coverage, we could see that in the long run, we would have a difference, and we would, in some cases, not completely reach the elimination target in a country like India, but still have very good impact. What you can see from these analyses particularly is what is the key issue around for all these modelings, and that is the duration of protection. So we can see that when the duration of protection is about 30 years, we can still have very good impact with a 1 dose and a lower efficacy. But when it becomes a duration of shorter time, such as 20 years, then really we can see we will not reach elimination. And in that case, it would really be important to switch back to 2 doses. So you can see all that here in these various models. And this modeling was done also to look at this, and Hilary referred to that, how many doses are needed to protect 1 case of cervical cancer. So here you can see that using a 1 dose can be particularly efficient. So you will use many less doses, and therefore resources of health workers and dollars, to prevent 1 case of cervical cancer. And this is the case really including when the duration of protection were limited only to 30 years. So all in all, SAGE concluded that the current evidence points to the same very high vaccine efficacies for 1 dose compared to 2 or 3 doses. Also, and we saw that in some of the graphs, that there's good evidence of stable and high quality immune response, and that the duration of protection, including through the bridging study we heard about, at the moment stands at least 10 to 11 years, which, and that's important to know, is the same time and duration of protection we know for the 2 or the 3 doses. So there will be upcoming evidence from the CVT study that will be published soon about the 16-year immune stability, and that will give us also a good indication whether indeed the protection, as it's currently expected by all the experts, to be at least 20 years. Of course, to get the evidence for the very long protection, we will have to wait, because HPV vaccines have been on the market only for 16 years now. So this is the same situation for 1 dose as well as for multi-dose schedules. So as a result, the SAGE concluded that there's sufficient strong body of evidence to make a permissive recommendation for a 1-dose option, and that the benefits for public health of 1-dose option outweigh the risk. So what is additional evidence that may be coming? And here one of the areas is evidence on HIV positive population. So this is recognized as missing evidence, but there is a study that will give, although a small sample, some indication about the 1 dose in HIV positive as well from South Africa. We will get this data from CBT on the immune response through 16 years. We'll get additional data from India IARC on the efficacy against neoplasias. And we will have the Escudo data that will come out in 24-25, which will be able to show the non-inferiority of 1 dose versus 2 dose. And that could potentially be the point where the evidence can indicate we can move to a universal 1 dose recommendation. So this, in summary, this is what the SAGE recommendations look like. 2 doses can now be used from 9 years onwards for all age groups for which the vaccine have been licensed. So the optimization is not just at the level of the primary target group, which is maintained at 9 to 14, but also along the whole spectrum of ages where we have gone down from 3 to 2 doses. The 1 dose can be used up to 20 years of age as an alternative. And for immunocompromised, including HIV positive individuals, it's recognized that the data is insufficient. We think that they should receive minimally 2 doses and ideally the same as we had before, 3 doses if possible. And there is some change in the prioritization. So where we were saying that the multi-age cohort and vaccination of boys and older cohort should be stopped due to the supply situation, we are now indicating that the max and the catch-up vaccination, also due to COVID, should be done as a priority, and that the introduction of vaccination to other secondary targets, such as boys and older women, should be carefully managed until the global situation of supply is fully unconstrained. So just to think of some of the implications also for NITAGs. One of the things is, of course, that currently not all products have the efficacy data for 1 dose. And so new products will need to immunobridge. We heard about Cervarix, Gardasil, and Gardasil 9 being mentioned in the various studies. And so these are now considered to have efficacy data for the single dose. But the newer products that have come to market, Secalin and Walrinvax from China, and Cervavax, which is from the Serum Institute in India, that has just been licensed in India and will soon be presented for PQ. They will have to do trials that we heard Hillary explain to immunobridge to these other populations and products that do have efficacy. So the other thing is then how to make decisions on 1 dose options. So the SAGE considers, and WHO will use the same language in its position paper, that this single dose option, which is off-label and hence a decision for NITAGs to take, it is an option for both routine and MAC catch-up vaccination, and it's recommended from a public health perspective because of the comparable levels of protection and providing higher efficiency and programmatic flexibility. So what are the things to look at for programs? Of course, what is the performance of the ongoing HPV program? The ultimate impact of the vaccine is determined really by the coverage. So if we don't have high coverage, why not? Then do we have high dropouts? And this could be a reason to consider a 1 dose option. Of course, the capacity of using a single dose strategy to boost coverage will be important. Is it a way that can lead to innovative delivery strategies, for example? Another issue can be when we introduce or when we want to reach higher age cohorts. When we move to a 1 dose, be it in the MAC or in the MAC and the routine, this can help us to reach twice as many cohorts with the same doses, resources, and hence the impact could be twice as large. And so that's a very important consideration. Also, moving to a 1 dose may require less funds and maybe make the program easier to both introduce or to sustain. And finally, when we take the broader view of the whole elimination approach and look at screening as well as vaccination together, there may be countries where the consideration is to move to a one-dose schedule and the freed up resources to use for improved screening. For the African region, of course, there's a particular consideration for the HIV situation and what that means. And I think, this is, of course, particularly true for the high prevalence countries, where many of which are in Africa. We do know HIV positive women have a 6-fold higher risk to develop cervical cancer, and they develop cancer at a younger age. So I think it's important that we recall that HIV positive population constitutes a very small percentage of the primary target. So, according to UNAIDS, in many of the even very high HIV countries, it is either lower than 1% and 4% in the highest affected countries. So even with the 4%, it means that 96% of the girls are HIV negative at the ages of vaccination. So, and also that the peak of HIV infection tends to be later, because most of the girls infected earlier are so from mother to child transmission in their majority. So most of the infections will take place later. The peak of infection is between 15 and 24 years of age, as you can see from the UNAIDS data. So, what is the implication of this? So if a single dose strategy can lead to a higher HPV coverage in the primary target, then the overall, including the herd protection of the population, increases. And this will benefit everyone, but including those who will become HIV positive at the later age, normally post-vaccination. So, however, of course, evidence is needed. What happens in particularly to protection when HIV positive women seroconvert after having received one dose of HPV? And so this is the kind of research that SAGE indicated should be done as a priority. The guidance that any person known to be HIV positive should obtain additional doses is not changing. We are saying that now they should receive at minimum 2 and ideally 3, which was very much the case before. So to a certain degree, one could say once we know the population, a person is HIV positive, we know they will need to receive additional doses. And that situation doesn't change with using a 1 or a 2 dose. So the new SAGE recommendation actually has been to make women living with HIV as a priority group, including older cohorts, so that there should be catch-up done to reach these groups overall. So more focus on this group, but also more research needed. So I think these are some of the key issues that NITAGs need to consider in the region. So finally, there are some countries that have already announced to change their HPV schedule. The first country to indicate so is from the African continent. It was Cape Verde, and they indicated that after their introduction last year, they will now move to a 1 dose and thereby use the resources to also catch up the 9 to 14-year-olds. The UK has indicated that as of next year, they will move to 1 dose from 9 up to 25 years in both boys and girls. In the Netherlands, they have not decided to move to a 1 dose for the younger group, but decided to move to 2 doses for the catch-up from 15 to 26. And we have countries in the WIPRO region that have also moved, and Tonga is the first country to introduce with the 1 dose. And the NITAGs have decided for some countries to recommend an introduction with 1 dose in their application to Gavi for the HPV introductions. So we can see that the SAGE recommendations are already being looked at, and as a last word, the recommendations are now converted in the WTO position paper that will be published, if all goes well, on the 10th of December. So in 6 to 7 weeks from now. Thank you very much.
For that presentation. As usual, we all look up to SAGE for those important guidelines. Clearly, what he has indicated has included the earlier studies, earlier presentations of Nelly and Hillary, and of course the data being expected from the otherwise primary group, like the HIV positive, will probably add to the recommendations that we're expecting. Now, I want to thank you very much for the presentation. Again, as usual, we would expect people who have questions to make those, to indicate those questions. I believe we can now go on to the recommendations from Nigeria. Needless to say that Nigeria had proposed introducing HPV vaccination since 2019. Well, we've had to rethink the strategy with the new evidence that has been presented. So the director of, one of the directors in HPC DA will present the Nigerian situation. Thank you very much, Dr. Posen, as we yield the floor to you.
Thank you, the chair, Professor Ibrahim. Permission to share my screen. Good day, everyone. Thanks for the opportunity to give these updates on behalf of the Nigerian team. We are giving updates on our one-dose proposal. On behalf of the Executive Director and the entire staff and management of the agency, we wish to appreciate all our stakeholders that have been supporting the country towards the planned introduction of a single dose in the country in 2023. We'll be looking at the basic background information, what our NGTAG recommendation on the use of the single dose has been, the factors that influence the decision for the single dose, our Nigerian introduction strategy, the status of country submission, and the next steps to the conclusion. The general background, just to mention also that for us in Nigeria, the cervical cancer, the morbidity and mortality is high, especially due to the poor effective screening, lack of presentation and on time, and inadequate treatment services that are available. We know globally only about 13% of the girls under 5 have access to the vaccine. The cervical cancer stands as the second most common in our country. Annually, we have about 14,089 new cases of cervical cancer, and 8,240 of them died every year. As mentioned earlier, usually due to delay in the access to reliable screening, delayed diagnosis, and inadequate treatment that has been responsible for this. Globally, it's also noted that type 16 and 18 causes approximately 70% of the cases. In the Nigerian context, as also documented by our NGTAG, the common strains in the country are the 16, 18, 31, 35, 51, and 52, with serotype 16 and 18 contributing about 66.9%, almost what is seen globally average. We also just hear from some of the studies done locally. We have also seen the evidences from the study of the work done by Thomas J. et al. In 2022. It's a recent publication. We've seen the one from Anthony Yu et al. In 2021, and then the one from Nanama T. et al. In Ibadan in 2004, all published documents in the country. Our journey started, if you want to say, from 2015, when we first of all applied for the demo, for a demo introduction in 2017, which was moved to 18, and that was not done. In the 2018, we now had the national planning and costing for the introduction, which was now integrated into the NCIP document of the country, that is the Nigerian Strategy for Immunization and Primary Care System Strengthening. That was when we now pre-applied for a full integration aside the demo that was earlier planned. And in April 2029, the NTAC made a recommendation to introduce the quadrivalent vaccine as the overall most effective and available vaccine. And then in July 2020, the application and the budget was submitted to Gavi. In September 2020, also Gavi communicated, gave us the feedback that had to do with constrained availability of the vaccine. And in May 2022, we had a meeting with the MEC, and of course, with the assurances we had and the communication with Gavi, we know also that we'll be able to have supply from them. And we now became committed to ensure that we introduce Gardasil 4 in the country. And then in June 2022, the team in country submitted the proposal to Gavi for possible introduction in May, June 2023. That is when we plan to do our introduction. We have also studied and again documented from the evidence available from our NGSAC the fact that if proposed, we will be able to serve in another almost 10 years about 71,000 deaths in the country. These are the projections and what it would look like from the in-country analysis done. Now, on the NGSAC recommendation on the use of the single-dose vaccine in the country, the first, as mentioned earlier, was initially we were to introduce 2 doses of the Gardasil 4, and the areas of deliberation was that of the rationale for the vaccine, the alignment with national strategy, the product's recommendation, and the strategic considerations. All these areas were looked at and discussions taken, and the NGSAC had deliberation on these key areas, which led them to the final recommendation that was made. On the rationale for the vaccine, of course, there were evidence showed that the prevalence of the cervical cancer in the country, as mentioned earlier in the background slides, are high. On the alignment with national strategy, it's already in our NCIP document 2018. We are targeting girl child 9 to 14 years. And the product recommendation was quadrivalent HPV recombinant vaccine to be used in the country in 2 doses. And then the strategies were to consider introduction in both sexes, but commencing having a phased kind of approach, initially targeting girls, and then the boys will be as a medium term. And then we also have data from the recommendation, we will use facility-based and outreaches in schools and out of school strategies for HPV introduction. Now, Nigeria plans to introduce the HPV vaccine in 2020. However, due to the global shortfall and evidence on the use of the single dose now, a revised request was sent by the new vaccine strategic introduction team to the NGTAC now for the change. And the research question that was shared with the NGTAC was, should quadrivalent HPV Gardasil 4 valent 1-dose schedule be introduced into Nigeria's routine immunization schedule for children aged 9 to 14 years, as against the previous 2-dose schedule recommended? This was the question to the team to address and guide. And to the right was the letter that was officially submitted to the NGTAC. The methods adopted by the NGTAC in the recommendations had the following steps. One, in the convening the HPV working group, the working group made 3 times 3 questions answered with peer-reviewed papers. There was a development of a recommendation framework. The framework had 4 categories we considered: the vaccine supply and availability, the vaccine immunization characteristics, and then immunization, economic and operational considerations we also look at. Then on the step 3 was to conduct the systematic search, and number of data reviews, articles and documents were reviewed on Gardasil 4. Evidence search, that was the step 4, and assessment on the Gardasil 4. At the 4 steps from the framing of queries and data ranking, the searching relevant peer-reviewed articles, quality assessment of selected articles, and synthesizing and making sense of the evidence. And then step 5 taken was updated the dossier and existing recommendation that was done in 2019. Here, the first draft of the dossier and reviewed recommendations have been completed and shared with the country. Based on the available evidences, the NGTAC recommended the Gardasil 4 quadrivalent HPV vaccine, one single dose, to be introduced into the Nigerian API schedule. Summary of the available evidences that was used by the team for the recommendation include the fact that 95 to 98% efficacy of the single dose schedule, which is quite comparable. So a 2 or 3 dose schedule was recorded. For effectiveness, there's 88.9 after the vaccination of a single dose for the serotype 6, 11, 16, and 18, which are common in the country. Increased availability of the vaccines for persons to be vaccinated in the in and medium country, low and medium countries. And of course, specifically Nigeria had secured commitment of the MSD to give the country 8 million doses in 2023, 11.8 in 2024, and 3.2 million in 2025. The other area of available evidence was that introducing single dose will alleviate current vaccine supply constraint, will address challenges of dropout, ease logistics and delivery processes for the vaccine. And then single dose regimen may reduce economic costs for introducing the operations were mostly on the schedule to be introduced in the routine nation as a viable strategy to address high burden of the cervical cancer. 2, for programmatic preparedness, the HPV vaccination should commence by 3rd quarter of 2023. Now, on the factors that influence the decision of the NGTAC and the technical team in the introduction in the country, they were mainly guidance on the HPV dose schedule from the search, the available single dose studies, vaccine safety, vaccine availability, economic and operational considerations. So on the first from site and other studies on the virus, that you have mentioned advantages and accuracy of over 95% efficacy against the HPV infection. So we have the details here. We're not going to eat the details because you've provided this information for these vaccines in your previous presentation. Thank you also, Nelly and Hilary, for making the work easier for us. We here in Nigeria, the technical to the work you have done, we have reviewed your work done, the Kenshi on efficacy in Kenya. We have also reviewed the evidences provided. And of course, I will not go into detail because in the course of your presentation, you've made our own easier here that I will not go into detail. Likewise, Hilary, on the Doris work done on immunogenicity in Tanzania, we also use these evidences. Our own NGTAC also use this as a means to recommend to the country. There was also the work done in India on efficacy by ARC, and also we looked at this. The other areas we also look at in the recommendation and the fact that there are several additional studies that are ongoing that will provide insight into this. Paul also made this very easier for us in his presentation. A lot of them, the results will be available in 2023, some 2024, some 2025. Some of the great studies and the great works that are ongoing are the one by Hope in South Africa on effectiveness, Primavera in Costa Rica on immunogenicity, also Escudo, Costa Rica is on efficacy. We have in Thailand impact study in Thailand on effectiveness, and then the HANS in the Gambia on immunogenicity. So we also look at this work that are ongoing and use them in making a decision. Now, as a country having made this decision and also being guided by our NGTAC and the available evidences globally on effectiveness and availability, we have our strategy to introduce the vaccine in school and out of school girls aged 9 to 14 years old. And of course, the Gardasil, as we mentioned earlier, the strains that are available in the country inform the choice of this. The target is for 9 to 14 years, and then they will be using campaigns for the year of introduction and routinized subsequently for 9-year-old in 2025. A single dose will be administered. We are collaborating with all our stakeholders to ensure vaccine acceptance and create demand, leveraging already on existing safety monitoring and adverse faithful immunization, and also establishing our country database to capture the HPV data. And just looking at it as a country based on the global guidance on single dose and availability of the quantity of vaccines that will be available in Nigeria in 2023, Nigeria will be introducing in phases. And here on the map, the green are those countries that will introduce in 2023. It will be as a multiple antigen campaign in 15 states and the Federal Capital Territory. And then the remaining states will introduce in 2024, and those will be in 21 states. The three criteria that we look at as a team for the phasing included the areas of the level of risk to cervical cancer disease, and the indicators we looked at here in arriving at this included the mean age of sexual contact, the percentage teenage pregnancy, the mean number of sexual partners in a lifetime, STI prevalence in the last 12 months, the percentage male circumcision and HIV prevalence. The other key area was the cold chain capacity sufficiency and also the penta-3 coverage as it relates to the NDHS. This was used in prioritizing the states for the different phases, and also giving a more broader information on the phasing to people. The main aim was to ensure equitable access based on disease burden, the cold chain capacity, admin coverage, and data from the surveys. So for our very first year, 2023, which will be the year of introduction, 15 states and the FCT 16 will be introduced in Q2 over Q3. The vaccine will be Gardasil for target age group, and then they will be 13 and 14 years. And then we are also going to come using the campaign style and structured school, community outreach, and fixed sessions. Then the target coverage will be 80%, and then the dosage will be 1 dose. Vaccines requirement for that year will be about 5.78 million doses. In 2024 will be a phase 2, the second year of introduction. We will be targeting the remaining 21 states in Q1 of 2024. The Gardasil for target age group 9 to 13 years, and then the service delivery will be same as in the first phase, and with 80% target, the dosage will be 1 dose, and then vaccine requirement will be about 15.4 million doses, which we have commitments. The phase 3 introduction will be 2025, will be routinizing the vaccine for girl child 9 years. At that stage, we would have cleared the 10 to 14, and we routinize it for the girl child at 9 years using school outreach and fixed sections. 1 dose also, the dose that will be required in that year will be 5.5 doses. So as a delivery strategy during the campaign, we'll be trying to reach the schools for outreaches and then the communities. The girl in school, both public and private school, conventional, and then other areas will be reached. And then to the communities, the out-of-school girls in the community, we'll try to reach them at markets, other social gathering. We also add other antigens in the course of it, and then religious houses will be visited, private sector, sanitary, and also will be displayed and given as add-on during the activity. We also will be introducing a bottom-up approach for the rollout of the advocacy, communication, and social mobilization activities. This includes the early stakeholder engagement of the country's roadmap to achieve the 80% coverage in the first year. So we'll be doing a lot, focusing on the girl child 9 to 14 years in school, out of school, special population. In other words, they had to reach the urban slum, security compromised area, the IDP camps, fragile settings, difficult terrains will be areas of target to make sure that none of them is missed. And then the special populations, as mentioned in the earlier presentation, will also be targeted, immunocompromised, special need children, and then the disabled. We're also reaching this girl child 9 to 14 years in so many ways. Those in school, out of school, special populations, special groups. And for each of them, we have activities that are targeted, pre-introduction activities, introduction activities itself, and activities that will be conducted post-introduction. We will not go into long lists because of the time we are given on the things that we want to do before the introduction, during the introduction, and after the introduction as listed here on this slide. And then prior to the implementation, Nigeria will conduct a rapid pulse check across the country on the knowledge on HPV. This will help kickstart the above advocacy, communication, social mobilization, engagement. A lot will be done. We will use the results from this research and nationwide pool to inform the kind of frequently asked questions and key messages that we are going to share. This will also inform our engagement with the media, airing of jingle, public service announcements, short videos on the HPV introduction, TV shows, phone-in programs, social media, YouTube channels, and so on, will be based on the results from this finding. There will be local community film shows, development and review workshop on the IEC materials on HPV, finalization and pre-testing of the IEC materials, development of IEC materials on HPV introduction to state, demand generation activities, leveraging on the existing community, use of the community influencers, community gatekeepers, and community mobilizers, community dialogues on the HPV introduction, and the town hall meetings will also be conducted. We have learned lessons from so many countries, and early commencement of advocacy communication will be very important to the introduction. On the vaccine quantification, also on the forecasting for the 3 years, you'll see shortly some of the areas we look at in arriving at the quantities of vaccine mentioned will included that of the total population for the girl child 9 to 14. We look at the percentage of female population 9 to 14, and then we also look at the target population of female 9 years old and the number of doses, the wastage on the target population, and then the buffer stock we put at 25%, and the routine coverage of 69% with an annual projection of 4% increase in the coverage as per the NCIP document. And finally, we also have built in the growth rate of 3.2%. So for the first year 2023, as mentioned, we'll be looking for in total from the cohort of 9 to 12, 14 years, the 15 state plus FCC 16, we'll be looking at the population there and the vaccine requirement in all, adding with the booster, we'll be looking at the buffer, we'll be looking at 8.15 million doses of vaccine. In 2024, for the routine 9 years target in the 16 state area introduced, and then the multiple antigen campaign for 9 to 14 in the remaining 21 states, we'll be looking at a total of 1.3 and 10.44 million doses, giving a total of 11.49 million doses for the introduction in 2024. And in 2025, we'll be looking at a total of 3.26 million doses, which will be purely routinization in the girls 9 years in the earlier 16 state and the 21 state that was eventually introduced. So what is the current status of the country submission? We've submitted the application and all the relevant required documents submitted. The country received pre-screening feedback from Gavi Secretariat, and areas of concern we also addressed. For now, we are waiting for IRC final comment and the decision letter from Gavi. On the project and feasible timeline of the introduction using the Gardasil 4, here we have submitted the application. We are waiting the decision letter. The review process was on. And then in Q1, Q2, we'll commence pre-implementation activities. Q2 over Q3, we'll introduce the vaccine. And in Q4, 2024, we are going to do the post-introduction evaluation. So on the next steps and conclusion, to commence early stakeholders engagement to identify the extended stakeholders, to commence review of the existing advocacy, risk communication, and the community engagement, which is the red. We'll commence the early development of the relevant training materials for the HPV introduction training, especially the risk communication and the community engagement. And then we'll commence early advocacy communication and social mobilization at least 6 months before the introduction, following those steps earlier discussed. And then in conclusion, the agency NPSDA, on behalf of the government of Nigeria and all the partnership here, we once again want to sincerely appreciate the ongoing support from all our stakeholders. Some of them are online here, some are not here with us. All those efforts to ensure that we have a successful HPV vaccine introduction in the country, we appreciate. And stakeholders are kindly requested to continue to be committed and supporting the country in the ongoing effort to ensure that we roll out the one-dose vaccine in our country. On behalf of the team, we want to say thank you for this opportunity to present. Thank you. Over.
Thank you very much, Director. Of course, clearly a lot of work has gone into this planning. We want to thank the Primary Healthcare Development Agency for this and also to thank the host for allowing us to share these ideas with the rest of the world. Of course, let me just point out that there are one or two things popping up in the question and answer sessions, and we need to address them so we can then go on to the discussion portion of this presentation. There is a question one from Garba Danjuma. Will there be new recommended age of administering HPV with the introduction of single dose? I believe that question has been answered, but the director may want to answer that. The other question is from Linda, Farmer Grants. Does this mean we need a booster 10 or 11 years after? And the third question from Benjamin Kagina himself to Hillary on the immunological assessment for non-inferiority study. You showed data on seroconversion, avidity, and GMC. Is there value in measuring neutralizing ability of the vaccine-induced antibodies? So I can ask the director, Dr. Kosin, to answer the first question, for anybody who wants to have the answer.
Okay, thank you, the chair. For now, I know we have heard in this particular meeting, we have seen some good practices in some other countries where they are doing 9 to up to 25, like we've seen in UK that is happening. For us, for now in Nigeria, the new age still remains 9 to 14 at the introduction stage, and in 2025, we'll routinize it for girl child at 9 years. So for now, the 16 state and the Federal Capital Territory that we'll introduce next year will use a multiple antigen campaign approach, and we give the girl child at 9 their own, the other age group 9 to 13, they're going to be involved in a campaign. 2024, the same will repeat for the remaining 24 states, and then in 2025, we go full blast routinizing it for girl child at 9. So that is where we are for now. As the need arises, and we will write back to our NGTAC, who are always there to guide us on a possibility of scaling up to other age group. For now, is 9 to 14. And as I mentioned also, for instance, we're looking at only girl child for now. Then in the medium term, we will look at the male, the boy child. So we're going for girls first, take the male as a medium term, and we'll be guided by our NGTAC as we have always been. Thank you, over.
Thank you very much, Director. Let me say that as much as possible, the answer should be as brief as possible, because apparently we have quite a lot of questions. Shall we go to the next one, which I believe maybe Hillary should answer this, because this booster 10 to 11 years after the dose.
So I mean, I think at the moment we can say from the data that we have, there are very good data that the immune response, a good immune response persists for at least 11 years. That's not to say we need a booster at 11 years. However, we are, as Paul mentioned, we're going to be having later time point data coming out in the next few years. So we do have time, if countries do want to introduce a one-dose schedule, we do have time to look at that data and evaluate that data before we even kind of approach this sort of duration. There would be an opportunity to to look at those data, and if we felt that actually the antibody responses don't persist for as long as we thought that they would, then there would be an opportunity at some point later to address that. But I think at the moment we're all fairly convinced that the data are very promising, that that there is a good, stable, sustained immune response.
I wanted to just
thank you very much.
I wanted to chime in on this, that this is actually true about a lot of products, even as we start. Even when we started with a 3-dose schedule, we did not have 10 years, 15 years. The data is accruing with time on durability, and it's true of many, many products. I think we had to wait for 20, 30 years to know about durability, would not be able to start.
Yes.
But the avidity data is the one that helps us say that the likelihood of durability to be similar across doses, I think, is the important part.
Thank you very much. The next question also is directly to Hilary on the immunological assessment.
Yes, the question of neutralizing antibodies. Yes. So I would start by saying, so at the moment, we don't have a known correlate of protection. I think that's important just to note. That being said, there is opinion that neutralization assays are the most relevant for measuring the biological activity of antibodies. So yes, maybe there is some value, or yes, there is likely value in measuring neutralizing ability. The downside, coming from somebody who's not done a neutralizing assay, so I hope that I'm representing this okay. The downside is that these assays are more laborious, not as high throughput as the binding assays. So obviously that is a consideration for these large trials that have lots of participants, lots of time points and so on. And I would say that another key point for the single dose trials and studies that are ongoing and planned is standardized measurement and reporting of immunogenicity. So those are factors that have played into decisions so far on the types of assays to be used. But yes, I mean, I think that, you know, some studies have looked at neutralizing antibodies, so there is certainly value.
Thank you very, very much, Hilary, for that answer. I hope it does satisfy the curiosity of other people. There are a series of questions here from Dorothy. Are there any safety concerns during any of the studies? Were there any safety concerns during any of the studies? Please, why the choice of meningococcal vaccine in the Kenshi study? And what were the serotypes to the few positive cases seen after the 1-dose vaccine? And finally, has there been a dose reduction trial in both vaccine, noting cost of vaccine, and has there been trial of reduced dose intradermal trial? Nelly, maybe you want to start with that question about safety concerns?
Yes, so we did look at safety in Kenshi, and we saw no difference whatsoever across the 3 arms in safety. And also, of course, we know that the primary trials also demonstrated very high rates of safety. In Kenya, there's a time we had a lot of very bad press around the vaccines, around fertility issues. And I think this often, almost always comes up when we have an intervention touching on young women. I think our communities are very protective of their reproductive potential. It wasn't good, but we had a lot of pregnancies, which is something we're struggling with because we provide contraceptive and counseling, but and maybe it's just the age that the girls were in. So no differences across the arms of delayed HPV with meningococcal and the nanovalent and bivalent. The question was asked, why choice of meningococcal? We thought that, I mean, the girls are going to benefit. It's good to have the meningococcal vaccine and be protected from meningitis. and we also needed the delay. And one of the reasons we also picked this age range, we're moving from what's already approved to an age where we could delay ethically, but we're still providing all of them with vaccination now that we have seen the benefit. I wasn't sure about the dose reduction. I'm not sure I understood that clearly. But I just want to also recall that, remember there was one infection in bivalent and the nanovalent arm for HPV 16 and 18 serotypes, and all of them occurred before 6 months. So we think that there are infections which were already there before vaccination. I hope I've answered the question. And I think, did we find a benefit to those who already had antibodies? Were they? Yes, so I think the questions, answers are there that we don't need booster. Hilary, do you want to answer about your findings in DORIS?
The findings for the, sorry, I was responding to a message in the chat. So yes, so I just put a message in the chat about safety. So we had no safety concerns in DORIS. We had quite a lot of malaria adverse events considered not related to the vaccine, but malaria, Mwanza is a malaria endemic area. And I was also just about to note that we also had quite a lot of pregnancies in DORIS, which was interesting because obviously it's the younger age group. But we did have quite a lot of pregnancies.
If I can come in on some of the issues that were raised here and in the chat as well. So at this last point, the question of reduced dose and intradermal trial, just for your information, there is one trial that's being planned with using a non-needle intradermal HPV application, which also used indeed small amount of liquid, which is 1/5 of a traditional dose. So there is some work around that, but that's at the moment very far from let's say leading to broad application. I did see, some of the questions around have the data and the one dose changed anything in the recommendation of the age, and the colleague from Nigeria, nicely responded to that from the Nigeria point of view. I think it's important to know that all countries that vaccinate do target primarily the girls' early ages. There's 9 in some, 10 or 11 in others. Also a country like the UK. So when they say 9 to 26, the older ages are their passive program, which allows catch up for anyone up to that age. But the focus of the program is vaccinated 12 to 13-year-olds because, and this was also asked, in some of the questions, sexual activity, how does it influence, etc. We just have to remind that we have to vaccinate primarily before sexual activity happens, which is, of course, as we know, very young in many of our countries. So there is a population of 9-year-olds who will be sexually active and 10-year-olds. But that grows with every age group. And that is potentially the one thing to consider when I heard I saw mentioned we could now do with a one dose, and that is true. We could do a campaign of the 9 to 14-year-olds every 5 years. So we think it's important to consider these options, and in some countries or maybe some regions, challenging areas of the country, this could be considered. But then, of course, we will be reaching more and more girls in that higher end of the 9 to 14 who will have been, exposed. So when we can limit that, the better, and hence the importance of, vaccinating early in the general program, and that has not changed with the option of the one dose schedule.
Oh, sorry, we're still on.
Yeah, there seems to be a bit of a silence. I didn't know, Chantal, do you have any more questions?
There are more questions, but I think we might have lost connection with Professor Ibrahim. So I don't know if somebody else wants to take over while he comes back online.
So maybe I can just continue the discussion and just introduce myself. I'm Gregory Hussey, a member of the niche team. I had a question in relation to the booster issues, and I'm just wondering, Nelly or Hilary, do you think that natural infection following vaccination will act as an immunological boost and thus sort of obviate the need for a potential booster vaccine? Any comments on that?
I actually don't know. I know that when people get the boosters, they get this amnestic response because the B memory cells that persist after vaccination, and whether or not natural infection would act. I don't know about available data that can inform us on that. The thing is that we are not seeing infections after vaccination. So I think we need to have how would I put this? So the vaccines have been highly effective. I think that's the way I see this, that these companies have made extremely effective vaccines, these virus-like particles. I think that's what I've heard Margaret Stanley, put it. And they do, almost act like when people have the natural vaccines. So whether or not the natural infection boosts or they just continue to be highly protective, I may not be answering that question well, because I don't like to speak outside of data. I don't know if Hilary wants to, or Paul, if you want to make a dive for it.
Well, I guess I'm in the same boat. I mean, it's something I've also thought about. I mean, I think it makes sense immunologically, but I also am not aware of any data particularly that shows that.
So I would assume
I can say that
what...
this was discussed at the SAGE working group, and I've heard John Schiller say that there are, in some individuals, there have been small blips, kind of, upward movements have been seen over time, and there was thought that it may be related to this. And then one of the things Margaret Stanley pointed out is that, the natural immune response is so much less good in its quality. It's incomparable with the vaccine. So, it is unlikely to have a big boost effect. But I think the way it was discussed was like, is it possible that it's underlying, for example, the more extreme stability we see with one dose compared to the 2 or 3 doses. So I think for now that it's more of a theory than anything else.
Okay, no, thanks very much for those comments. I'm not sure if Professor Ibrahim's back with us. If not, maybe we should continue with the questions 8, 9, and 10. The question 8 is in relation to contraindications in terms of age, underlying disease, or drugs. Comment from our panelists?
Well, I can say that from, say, the position paper, and we look at the latest evidence, I mean, it continues to say that in general, there are no contraindications. Well, in terms of age, we could say that the vaccine is licensed as of 9, so that would make earlier age a contraindication. Interesting to note that in the Gambia study is actually ongoing in vaccinating either 6 to 9 or 4 to 9 years old. And there has been a study done by one of the companies showing a safe response and a good immune response. So there is work going on looking at age. In terms of underlying diseases, there's no particular diseases that are mentioned as contraindications, except for allergic reactions to components known to be in the vaccine. which so that's, I think, that's a generic issue, not specific to this vaccine, but definitely, of course, to its components. And pregnancy at the moment is like a contraindication, although again there it's because there's no evidence on the safety at large scale, but all the post-marketing studies that have been done and the databases that are kept on this indicate that there is actually no risk, both for the mother or the child, of being inadvertently vaccinated during pregnancy. So very, very limited contraindications in that sense.
Thanks, Paul.
Just a reminder that most of the adverse events that we have observed are injection sites. And then the systemic ones are just the usual you get with other vaccines, the headaches, maybe some muscle ache.
All right, can we go on to question 9? It's the issue of cellular immunity. And the specific question is, are there evidence of significant cellular immune responses, especially in this 2-dose regimen in the long term? My understanding is that there are good immune responses, both humoral and cellular, with the single and 2-dose or even 3 doses. I'm not sure. Hilary, do you want to comment?
Yes, yes. I mean, there is evidence of cellular responses following the various different dosing schedules. I can't tell you offhand what the question asked about long term. I can't tell you offhand what time point those data go up to. But yes, there are data on cellular responses following the different dosing regimes.
But we would assume that given the available data that we have in terms of follow-up stretching out to 10 to 15 years in terms of protection, that there is indeed good both humoral and cellular immune responses.
Yes, yes, and in Doris we, I mean, I know the question asked about 2 doses. In Doris we are looking at well, we're looking at B cell responses at some of the later time points. We don't have all of those data for the later time points yet, but so we will have those data. We're not looking at T cells in Doris.
Okay, good. Thanks very much. We have about 10 minutes left, and I think there are quite a few more questions. So if we could go to question 10. Would Nelly, Paul, or Hilary respond to that?
Looking at that. So yeah, you're right. Efficacy is not a question. That after some months antibody decline, what happens is across all 3 of them, 1 dose, 2 dose, and 3 dose, they seem to reach steady state across trials. And after month 12, month 24, then the antibody levels don't seem to continue declining. They seem to hit this plateau that's continuous. So the plateau for 1 dose is lower than for 2 doses, and 2 doses slightly lower than for 3 doses. The important thing is this plateau that has been observed. And I think that's why the CVT data and the India data was so reassuring to continue seeing that plateau 10 years into that observational cohort data.
Thank you, Nelly. Chantal, can you put up the other remaining questions in the last few minutes? All right, so we have 2 more questions. 11's a very interesting question, and I suppose it relates to issues around the program and also around cost of routine versus mass campaigns. And there's been quite a lot of debate in the past about mass campaigns generally for vaccinations. So Paul, do you want to respond?
Yes, I think I already alluded to this question earlier. So, I think this is the kind of flexibility that a one dose may provide. We do point out, and the position paper will make that point also strongly, that as is the case in two-dose vaccination, and it may actually be not related to how many doses are in the schedule, it is important that girls get opportunities to get the dose they missed, which could be the first dose, or in other countries the second dose, which is one of the reasons why with a massive campaign, particularly if it doesn't reach high coverages, is something that should be looked at. And we saw in another comment that of course, the campaign could be then complemented with having the vaccine available in the facilities for those who have missed it. So I think that is important to see, but definitely in some places this could be this could really be a strategy to be used, whether it's 9 to 14 or or a different age group like 9 to 12, and use 3-year campaigns, which in one of the modeling had been shown as being kind of a sweet spot between avoiding the higher ages and being very efficient in your delivery. So I think this will be interesting, but this importance of allowing opportunities to always get your second dose or your first dose up to the age of 15, so as young as possible, it remains very important.
So Paul, are you aware of any countries that are thinking about, for example, they are planning to implement a strategy for 9-year-old girls, starting, say, for example, in 2023, but as part of the overall program, they're going to do a mass catch-up campaign, say from 9 to 14 as a start?
So most countries, well, all countries that apply to Gavi support have indicated that they will do that. And I think what you saw in Nigeria is the same. Nigeria needs to do it, however, over a couple of years, because it has such a large cohort that the production cannot keep up with that. But many countries have done that. Zimbabwe has done it, for example. So actually that is now almost the norm. You start 9 to 14 and then you continue with your 9-year-olds, or some countries use 10-year-olds. And I think that is what is done a lot. And now some countries and these countries with more resources sometimes introduce and then allow all those up to 26 to come in, but they not do that, not always through campaigns, but rather through passive approaches. So I think that is really important, and the position paper will now reiterate that given that we start to have the doses available, we should really try to do those multi-age catch-ups to have impact earlier and have more resilient programs in case something comes along that affects the program for some time.
Paul, is Professor Ibrahim back? I've just taken over the chair because we lost you somewhere along the way.
Thank you very much for stepping in. Yep. Can you hear me?
Sorry, I wanted
to hear me?
Yes. I wanted to say that in a recent meeting we heard from Ethiopia that they did these large national mass campaigns and really increased their coverage, went up crazy mountains and basically really made a huge effort to reach all their age eligible girls. So I think what Flores Kalabamu is asking, the Ethiopian teams can even share more from their program experience.
Is anybody from Ethiopia online? Just to give us small. Ethiopia?
If you can raise your hand, if you are online, anyone from Ethiopia who wants to.
Apparently none, but I think we can take your word for it, and perhaps some countries may want to take that kind of approach.
Yeah, or just reach out to their colleagues in Ethiopia.
Have we? Okay. Yes, which, all right, is that question number 12? Has question number 12 been answered? Considering the dose efficacy of a single dose of both vaccines and the about 10% cost difference between Cervarix versus Gardasil. Gardasil has dual protection. Could that be an advantage in selecting Gardasil?
So I would like to
Dr.
say...
Boson, can you answer that question? Okay. Please go ahead, Paul.
So what I would like to say, and I think what I welcome very much is the awareness of cost, and we think that's very important. So looking at cost for selecting the vaccines, in this case, you make the example Gardasil Cervarix. You saw from Dr. Opossum's presentation that there is now another product on the market, Secolin, that has an indicated list price of $3. So that is actually 30% cheaper than Gardasil, for example. So I think it's important, and that's the guidance WHO has given, that all vaccines protect very well against cancer. They have excellent efficacy, very good immunogenicity. They all have different characteristics that may favor them. Cervarix has a 2-dose presentation that may be good for the cold chain. Gardasil protects against warts, which is another example. And there are costs that are there. So it's important countries are aware of cost, and that they will be able increasingly in the future to choose between vaccine products and thereby obtain better prices also. And this is particularly important for middle-income countries. So actually, to some degree, just looking at how many types are in the vaccine, for example, may really not be the only thing we should look at.
All right, thank you. There is a question from Daniel Dio. What have been the contributing factors for reduction of second and third efficacy? How has aging been considered under this scenario? Sorry. I don't know whether Hillary, can you? I know that you mentioned.
My apologies. I don't quite understand the question. I'm not sure if Paul or Nelly.
Sorry,
Yeah,
I didn't understand the question very well, but potentially if it's asking about if there's a difference between if you vaccinate when you're older or younger, it's not clear to me.
Yeah, the first part of the question that I thought was something about what Hillary mentioned regarding well, she literally called it an accident, but those dropouts that were eventually followed as cases, and they now found that they were their response was almost as good as those who continued. I was wondering whether that's what you wanted to find out.
So, So
Sorry, carry on, Paul.
Yeah, I'm just looking at the question. I mean, one thing of thinking it's true that when we started to vaccinate, it was 15 to 24-year-olds, for example, that got the 3 doses, and the younger ones got 2 doses. So it's true we have more data and different regimes also somewhat applying at different ages. But however, the data is actually showing that the efficacy, particularly in those who were naive for the HPV types in the vaccines at the onset of trials, is exactly the same. So in that sense, I think even the different trials have shown there's no age effect as such. So yeah, I think that's how I would interpret this question. And the 1 dose, I think, is very important that we recognize it has been, it has been shown in a younger age group. It has been shown in 15 to 19. So we kind of, cover and have followed up women who received 1 dose, up to 20 years of age, and followed some of them through until they were 30. So, we can see that the efficacy was not different also at ages around 30. Having received 1 dose only, which was the case in the CVT trial, for example.
I think because there's a question about people who are already sexually active and whether it's being therapeutic. It's a prophylactic vaccine, but it's always a good reminder that being sexually active doesn't mean that you've had prior exposure, number 1. 2, if you've had prior exposure, it doesn't mean you've had prior exposure to all the oncogenic HPV serotypes. And actually, there's some small studies that have been done where people were giving HPV vaccine to people after being treated, and what showed a reduction in recurrence, which was probably protection from the HPV serotypes that they did not have at the time of infection.
I think we've asked our
Ms.
chair
Angio
again.
tried to reframe the question, but I don't think it's still not very clear what he's trying to find out. But I think what we've had is adequate for now. All right, any other comments or questions? Okay, I'm not sure that it is Benjamin.
Yes, Professor Ibrahim. So
yes. Is there any other thing? Yes.
So now maybe we're going to move to the next session, which is a closure, and that will be done by Professor Greg Hassey.
Thank you very much. Prof,
thank you so much.
Can we? Yeah. I'm sorry for all the glitches.
Professor. No problem at all. I think we well past our closure time. It's now almost 2:10 local time. But thanks very much for chairing the session, Professor Ibrahim, and also to the Nigerian NIPAG for co-hosting this webinar with our NISH team. I think just a word of thanks to all our speakers for the excellent and very clear presentations. And to me, it's wonderful for once seeing Africa being at the forefront, not only to research, but also with respect to policy in the context of the single dose HPV vaccine strategy. I the participants. It's been a well-attended webinar, and for all the questions raised. We've had our translation team working hard in the background, and hopefully it's worked for our French and Portuguese speaking colleagues. But it would be useful to know from you if there have been any issues, especially in terms of moving forward with translating our future webinars. And then just lastly, to those who have participated in the webinar, there is a short survey which will take a minute or two for you to complete. If you go to the chat, it's around what should the next webinar focus on. So please, if participants could very briefly complete that survey, it won't take a minute or two. So thanks once again to all of you. It's been a wonderful session, and enjoy the rest of the day. And we hope that we will all act as advocates to ensure that all our countries in the region look towards introducing HPV vaccine into the programs in the near future. So once again, thanks very much for your participation.
Thanks so much. Goodbye.
Thank you very much. Bye-bye.